Thank you very much, madam, for your time. And Dr. Sukanya, madam, is also online.
Yes, good afternoon. Good afternoon.
Madam, good afternoon. Thank you very much for your time, madam. You have been our regular person in the program, scientific program. Thank you so much for your time. I know that you may not need any introduction, but the formality, we should definitely introduce you as a chairperson for the session. Dr. Sukanya is highly experienced and she's a consultant microbiologist and infection control specialist. And madam comes with a high qualification in terms of MD in clinical microbiology and has also done multiple certification in infectious disease and infection control. With over 19 years of experience in diagnostic microbiology, infection prevention, antimicrobial stewardship, and quality accreditations. She currently serves at Medgenome Laboratories and Motherhood hospitals. She is passionate about improving patient outcomes through accurate diagnostics, effective infection control, and collaborative healthcare practices. And Dr. Sukanya has contributed significantly to the medical community through her publication, conference presentation, training programs, while also playing a key role in shaping up infection control and antimicrobial policies in various healthcare settings. Dr. Sukanya is a well-respected consultant, educator, and speaker, contributing to numerous peer-reviewed journals, conferences, and training programs. To name few of her achievements, she has been extremely good in academic career, so published 12 articles in peer-reviewed journal, and also presented as a speaker in 30+ forum and conferences, and organized over 20 CMEs, workshops, and training programs, and completed 5 research projects, and completed 12 formal training programs in microbiology, infectious disease, quality, and accreditation audits. Thank you very much, madam, for your time. It's a brief introduction. We can go on introducing you. Thank you so much for your time. And
thank you so much.
Thank you so much. Dr. Madam Bhavi Ramesh, also thank you so much, madam, for picking up your time from your abilities. And now, as SANMED, we welcome both of you. And
thank you so much.
And we look forward for your valuable contribution to the session and also help your expertise and experience in sharing so that others also can learn from both of you, madam. Thank you so much. And session handed over to Madam Dr. Sukanya. Thank you, doctor.
Thank you, Mr. Ganesh, for that wonderful introduction. It's really nice to work with SANMED. I've been a part of the masterclass sessions, and it's been something very different, which SANMED has actually been doing over so many years. There were a lot of variety of topics starting right from the pandemic era. And it has been extremely helpful when online really became more famous. When we had more of virtual classes online, it really helped a lot. It also brought together a lot of experts on the same platform. We in fact got to know each other better. There's a good amount of networking among experts, both academic and clinical. So that is something which I would definitely I'm very grateful to SANMED for. And talking about this Masterclass 6, which is basically on this surgical site infections, advancing surgical site infection prevention, a comprehensive way of preventing SSIs beyond the incision, is something very creative as a topic. And I think we have finished one session already as to preparation of the patient. Today, the session basically is on preparation of the operating theatre. And I mean, it's my pleasure, in fact, to welcome ma'am, Ms. Bobby Ramesh. Ma'am, a hearty welcome to you. We are very grateful for your, valuable time, which you have, basically spared us today with your presence and your valuable experience, and your talk will definitely prove to be the same. Let me introduce ma'am. Ms. Bobby Ramesh she is a very famous person. She has actually got the most promising personality award in nursing excellence by the magazine Medgate today. Presently, ma'am is working as the group director for nursing excellence at Sarvodaya Healthcare at Faridabad. Ma'am is basically from AFMC Pune, which is a very prestigious institute in India, with 29 years of experience in clinical, teaching, and nursing administrative domains. And she has played a variety of roles, right from group nursing director, regional director nursing, and and she has also served in very prestigious hospitals like Jeslock, Mumbai, as well as Apollo Hospitals in Hyderabad, and India Operations Divisions of Parkway Pantai Limited. So, ma'am is also, when we talk about not only her clinical and her nursing and her administrative excellence, she is also into a lot of accreditations and quality training programs, I believe. She is an NABH principal assessor as well as a faculty for NABH and nursing excellence training program. That speaks volumes of her experience and her academic excellence. So, ma'am, I warmly welcome you with a lot of hope, and I'm very interested to learn a lot from your session. Welcome once again, ma'am. Please, you can proceed with your session. And any questions which the audience has, any of the participants, please do put it up in the chat box. We will take it up at the end of ma'am's presentation, and we can have an interactive discussion after she finishes. Over to you, ma'am.
Thank you so much, Dr. Sukanya, for that wonderful introduction of mine. And I'm thankful to SANMED for this opportunity so that I can reach out to many and do a training session on surgical safety beyond incision. So let me go to the topic for today's discussion. Yeah. It's a big show. It's awesome.
Ma'am, I will shall I share this presentation from my end? Yes, it is sharing. Yes.
So my topic for today's discussion is addressing surgical site infections beyond incision, comprehensive prevention and control of surgical site infection. This will be this much only, or we can have it wider? Manisha?
Ma'am, if we share the screen, it will be wider. Shall I share from my end, ma'am?
Yeah, you can share it because I am sharing the screen. You all can see this?
Yes, ma'am. Yes, we can see.
Ma'am, it's visible.
Yes,
but as you rightly said, it's not occupying the full screen. So
it has to occupy the full screen, but in my laptop, I'm not able to do it.
Okay.
So if you can do it, it would be fine. Come, Manisha, could you please share this introduction?
I think they could. Yeah, definitely.
Yeah.
Yeah. Okay, ma'am. Okay, I'm sharing. Okay. Yes, ma'am. You can able to see the screen.
It's the same, right, as that last time?
Sorry? Sorry.
It's the same height. It's the same. It's not really. Is it occupying the full screen?
Yes, ma'am.
Okay.
Okay. Okay, ma'am. You can start the session.
Hello. Now, may I know the audience here? The audience, are they nurses? Are they technicians? Are they infection control people? Who are the audience whom I'll be taking this session for? Hello.
Yes, ma'am. I think, Manisha, could you throw some light on who all have registered? Are they more of nurses or infection control? I think there are a lot of doctors, ma'am, as what I could see at, and there are a lot of nursing and infection control professionals.
It's a mix of doctors, nurses, and technicians. Okay.
That's right.
Okay. So now coming to the introduction to surgical site infections. Surgical site infections are infections that occur at the site of surgical incision, affecting the patient's recovery and overall health. And surgical site infection is one of the hospital-acquired infection. And the statistics, if you see, the SSI rates range from 19.4 to 36.5 all over the world. In India, it is somewhere between 3% to 12%. Even that is worrying, because a patient with SSI is 5 times more likely to be readmitted after discharge, 2 times more likely to spend time in intensive care, and 2 times more likely to die after surgery. Isn't that alarming? Nobody would want to come to a hospital to do a surgery and then die because of a surgical site infection, or get readmitted because of a surgical site infection. A patient with MRSA is 12 times more likely to die after surgery. When it comes to surgical safety, it is one of the 10 essential objectives for safe surgery given by WHO guidelines for safe surgery, because safe surgery saves lives. Care has to be taken to minimize the surgical site infection, but by using appropriate measures before, during, and after the surgery. When we talk about preoperative strategies, screening and decolonization is very, very important. Nasal mupirocin for MRSA carriers, chlorhexidine bathing preoperatively, and patients with high glucose level have to be brought under control. The blood glucose levels has to be brought down to less than 180 mg per dl to reduce the risk of SSI, because many a times SSI, when you do the root cause analysis, it would be mentioned that patient's glycemic index was not under control, patient's blood sugar levels were high. So that is one of the reasons. Smoking cessation, patient should be educated and told to stop at least 4 weeks before the surgery for better wound healing. And the patient should take adequate protein-rich, vitamin and zinc-rich diet for tissue repair. For GI surgeries, mechanical bowel preparation with antibiotics can reduce SSI. And as you all know, surgical antibiotic prophylaxis has to be given. The dose has to be given as per the policy of the hospital, and redose has to be given if the surgery is lasting more than 3 to 4 hours. And if surgical antibiotic prophylaxis is ensured as per your hospital antibiotic policy, definitely many of the SSIs can be avoided. No shaving has to be done. Clippers have to be used instead, because shaving can lead to cuts on the skin, which can lead to further infection. Now coming to the operation room. Operation room, apart from your surgery inside your incision, your operation room plays a very important role, and your CSSD also plays a very important role in the prevention of SSI. The operation room traffic has to be controlled. Many a times when ICMs go for rounds, or even if I go on rounds to the OT, when you stand and observe there, when a surgery is going on, there will be people walking in and walking out of the operating room. And many times even the surgeons do complain that, staff are walking in and out. That leads to, definitely more contamination of the OT, and it will be a root cause for an SSI. If a surgery is planned and scheduled for a particular OT, all the required things for that surgery has OT nurse in charge and the OT manager. All these things, if it is made available as per the schedule and as per the type of surgery happening, once the surgery starts until the surgery ends, nobody should be moving out of the OT. So if people don't walk in and out, definitely the traffic can be controlled, and definitely if proper planning, proper scheduling, proper preparation of articles prior to surgery is done, in between than running to stores and to get other things. And people even walk out for taking a break also unnecessarily. They will walk out and then they will walk in. These must be avoided. And the normothermia has to be maintained. The core temperature has to be maintained around 36 to improve the immune response, more than 36 degrees centigrade. The personnel working in the OT, be it the doctor or the nurse, all have to adhere to the hand hygiene and aseptic techniques. They have to use the PPE properly, your surgical mask, your gown and gloves. Sometimes, many a times, not sometimes, many a times you can see people walking out of the OT in the same scrub and walking back inside. When we have different areas of OT and OT is supposed to be a sterile zone, you cannot go around in scrub outside and then walk inside with the same scrub, and then you cannot operate on the patient. The OT in charges have to be strict about this policy that nobody should be allowed inside in the same scrub and then they walk to the canteen, they walk to go for rounds, they go to the canteen, take a break and come back in the same gown. If they have to enter inside the OT, then they have to change the scrub, they have to wear proper PPE accordingly. Surgical care improvement projects have to be followed, as I already mentioned. No shaving, hair clipping, warmers have to be provided, proper oxygenation, proper surgical prophylaxis, and Foley's catheter has to be removed within 48 hours. And instrument cleaning and sterilization process plays a very important role in the prevention of surgical site infection, which we will be discussing later. Now, surgical scrub is the most important step. They need to be using skin decontamination, should be used with appropriate antiseptic agents, and they have to use proper method, that is surgical hand scrub, for appropriate duration from 2 to 5 minutes. They should be doing the scrub, and they can use chlorhexidine or povidone iodine as well. You need to have foot operated tap and a proper big sink. Before doing a surgical scrub, one must remove the rings, the ornaments, whatever they are wearing, the watch, etc. And they should clean the fingernails with a brush. And then starting with the fingers, apply soap, antiseptic to all surfaces of hand. Rub between the fingers. And then the antiseptic has to be applied till the elbow. Starting with the fingers, they have to rinse each hand with and arm till the elbow, with the hands above the level of elbow. The hands should be raised above the level of elbow, and then it has to be dried with a sterile towel, starting from the fingers till the elbow. And the scrubbed hands must be kept above the waist level. Now, cleaning of the operating theatre. Daily, the operation theatre has to be cleaned. There has to be damp dusting of the surgical lights reflectors with approved disinfectant solution of your hospital. And then it has to be dried with a clean dry cloth. And all the furnitures, including the table, the ring stands, the operation table, all these have to be wiped with disinfectant solution. And the wet vacuum has to be cleaned as necessary. And in between the cases, all the litters from floors have to be deposited in waste container as much as possible. The litters have to be dropped into the appropriate biomedical waste collection bins. All the linen has to be collected and disposed in appropriate hampers for the laundry, be it a used linen which may be dry, and be it soiled linen which may be soiled with blood or body fluids. And discard any soil sponge, suction canisters, tubings, and other waste as infectious waste as per biomedical waste management rules. Depending upon the contamination of the floor and the procedures involved, the floor has to be cleaned between places. At the end of the day, after in between cleaning, at the end of the day, one has to do a thorough cleaning. All the soiled linen have to be removed.
Hello, ma'am.
Ma'am,
Hello, ma'am.
I think Manisha, her voice is, maybe there's some signal issue.
Ma'am, your voice is not audible.
Is it? Can you hear me
Yes.
now?
Yes, ma'am. Yes, ma'am. We can hear you.
So once at the end of the day, all the equipments in the operation room has to be damp wiped, and then it has to be dry wiped as well with appropriate disinfectant solution. And all the operating table cushions and removable pads have to be removed, cleaned, and then it has to be made. If the walls and ceilings have got soiled, if necessary, that has to be cleaned as well. A terminal and a thorough cleaning routine may be performed in addition to the end of the day cleaning. All the removable equipment and furniture to the hallway, it has to be removed to the hallway, and then all the area, all the equipments, including your air conditioner grills, all the shelves and cabinets, overhead lights, everything has to be damp wiped with disinfectant solution. Can you hear me? Hello?
Yes, madam.
Yes, ma'am.
And empty all the soap dispensers, your disassemble foot pedals, and clean dispensers and foot pedals. The cushions and pads have to be scrubbed. The entire operating table has to be thoroughly cleaned. Then the operation table has to be remade. All the furnitures, after thorough cleaning, all the furnitures and equipments have to be brought back to the room. Now, disinfectant mopping, at least 3 times mopping daily has to be done.
Ma'am, your voice is not audible. Ma'am? Bobby Ramesh, ma'am?
Of
Your
when?
voice is... Yes,
Hello?
yes, now you are audible. Now you are audible, ma'am.
Was it? I don't know, maybe network issue.
Yeah, it may be network issue, madam. Yeah.
I kept it full volume. 1 second. As I'd already mentioned, a clean operating environment is essential to prevent SSI. The OT is cleaned and disinfected to prevent microbial contamination. And whatever sources of infection in the OT are, the exogenous sources are people, anesthesia equipment, surfaces such as walls, floors, furnitures, etc. Hence, as operation theatre is a very high, sterile and aseptic and restricted area in the hospital setting, because of that, it's mandatory for all the personnel to have proper understanding of the working of the operation theatre, abiding by your protocols and professional guidelines. Integrated infection control in the operation theatre is the key to decreasing morbidity and mortality.
Ma'am, you are not audible. Hello, ma'am. Hello, ma'am. Hello.
Is a protective zone.
Hello, ma'am.
I'm not able to, it got.
It may be a signal issue, madam. I think Manisha can do a presentation from our side.
Because every time I need to tell her to.
That's okay, madam. We will move the slide once you are
Slide.
done. Next, that she will do that.
1 second.
Yes.
So we need to have 4 zones, and staff have to be educated about these 4 zones. And if in clean zone, the protective zone, wherein the 11 of the zone 1, zone 2 and zone 3. Zone 3 is supposed to be the ultra clean and aseptic zone. And staff who have to enter the zone 3, they need to wear proper sterile PPEs and they have to follow the sterile protocols. They should not be walking up and down between all these. The traffic has to be controlled accordingly. Now coming to the ventilation and design requirements, because you need to have HEPA filters. These requirements are very much required for the operation theaters. The air should be circulated by positive pressure through high efficiency particulate air through HEPA filters. These HEPA filters are special filters which can remove particle greater than 0.3 micron. HEPA filters should be monitored once in 6 months. These HEPA filters should be monitored for efficiency on a regular basis and changed when required. If the OT is and then the sterile air would be coming, and then there should be return air ducts in the 4 corners of the OT. Many times they may be keeping some trolleys and obstruct the return air duct. So this has to be ensured by the staff working in the OT that return air duct should be there in 4 corners, and return air duct should not be obstructed with trolleys with consumables and other equipments. And HEPA filter has to be validated once in 6 ensured, because the fresh air component is required. Out of these 20, fresh air component required is 4 air changes.
Hello, ma'am. Hello.
Looks there is a signal problem, Anisha. She's not able to speak. I think she'll get connected again.
So if ma'am can connect with her data, then using Wi-Fi, maybe it will be more better. We could suggest that. Somebody use your data and connect with the hotspot. That works better sometimes.
She's now out of line, madam. She's not there. I think we can call her up and then inform.
21 plus or minus 3 degrees centigrade, and humidity between 40 to 60. And the ideal humidity is 55%. Now you need to have an instrument cleaning area. The instrument has to be cleaned with soap and lukewarm water for at least 10 minutes to remove all the adherent visible soil. If you don't remove all these visible soil, the blood and other debris, it cannot be sterilized properly. The sterilization will not be effective. Hence, it has to be immediately washed and cleaned. Contaminated instruments have to be placed in closed leak-proof containers. And manual cleaning has to be done for delicate instruments using a soft brush with enzymatic solution. Hospitals, cleaning is done in all the cleaning is done in the CSSD. So the preliminary washing for removal of soil, the blood should be done so that it doesn't dry up, and then it has to be sent to the CSSD. In some hospitals, the OT itself, they will clean and then they will wash and then they pack it. So then they have to use enzymatic solution for proper cleaning. Then ultrasonic cleaners are available, in which high frequency sound waves are used to help remove debris. and washer disinfectors can automate the cleaning process. After cleaning, the instruments have to be inspected for damage, rust, cleanliness under good lighting. And as per the checklist, for a particular surgery, the instruments have to be arranged accordingly in the sets. Then it has to be wrapped.
Hello, ma'am.
Sterilization wrap or medical grade paper. The sterile items must be stored in a clean, dry and controlled environment. First in, first out principle has to be followed so that expired items are not stored and kept unnecessarily. And various indicators have to be used for effective sterilization. Chemical, biological, mechanical indicators are used to monitor sterilization efficacy. The sterilization logs, the load records and maintenance logs have to be maintained so that if any SSI happens, you have to start from the root cause analysis from the CSSD to the OT and then to the wards, and then other aspects have to be looked into. So when we do a root cause, maintaining these logs will be definitely helpful to check. So these are the various autoclave for autoclaving or sterilization. You'll be using chemical indicators, biological indicators, and Baudic. At the beginning of each day, you need to use a Baudic for any air leak. And the color changes. The staff have to be trained. Staff, including doctors, have to be trained by the CSSD team how the chemical or how the chemical indicator looks like before sterilization and post sterilization, how the color changes, so that when these indicators are put inside the sets and these sets are opened in the OT only, if the color has not changed, they should not be using the sets and they have to be returning it to the CSSD for re-sterilization. So until unless the staff and the doctors are oriented to walk the color pre-autoclave and post-autoclave, they will not be able to track it when they open the set for surgery. And if the set is not sterilized properly and the color has not changed, then the patient may end up with a surgical site infection. Same with the biological indicator. The biological indicator they are putting, and then it is sent for a culture. If there is a growth which is happening, post the surgery, the report comes in many places. From the biological indicators, culture report comes post the surgery in many places. In that case, the surgeon has to be intimated and the patient has to be closely watched for developing any SSI or any antibiotic prophylaxis has to be given. Now, the dressings have to be kept intact, and whenever required only the dressing change has to be done. Staff need to be trained. All the aseptic techniques, staff and doctors have to follow proper hand hygiene for doing and assisting in the wound care dressings. And this proper surveillance has to be done for any early detection of redness, swelling. So when a patient goes home, patient has to be educated that if at all patient develops any redness or swelling or purulent discharge, apart from visiting the OPD, even before that, if they develop, they should immediately contact the hospital and take medical assistance. The prophylactic antibiotics which are given, it should be discontinued until unless indicated 24 hours, within 24 hours post-operatively. Patient has to be educated about the importance of self-care and hygiene. Many times in the hospital, we follow all these techniques and sterile techniques, wound care guidelines, everything properly, and the patient goes home, doesn't follow proper hygiene, doesn't maintain cleanliness, and the patient comes with signs of infection. Hence, patient have to be taught about the importance of personal hygiene and self-care. And if the patient is on urinary catheter or drains, the catheters have to be removed within 24 to 48 hours until unless medically necessary. And the drain usage has to be minimized and removed as soon as possible. The blood glucose for diabetic patients and all, it has to be maintained less than 180 mg per dl post-operatively to prevent any infection. So as I had mentioned, beyond the incision, we need to be looking into the operation theater, the cleaning and disinfection of the operation theater, appropriate PPE and following sterile techniques by the staff, including doctors in the operation theater. The OT air conditioning has to be looked into, need to have appropriate HEPA filters with 0.3 micron, and every 6 monthly the validation has to be done, and if required, whenever required, depending upon the load of the hospital, it has to be changed. And CSSD has to be, one has to have a proper CSSD. Both CSSD and OT should have proper zoning with a clean, sterile and unsterile area, and people have to follow the protocols as per the zoning of the OT and the CSSD, and all these protocols have to be followed. In the CSSD, they need to use physical, chemical and biological indicator as per the requirement. If you are following all these, and the patient has to be educated well before the surgery, and post-operatively the patient has to be educated, and just when the patient is getting discharged also, patient has to be educated about the wound care, patient has to be educated about the personal hygiene, and patient has to be educated about the signs of SSI inventory. So by doing all these, we can definitely prevent SSI to a large extent. Thank you all.
Thank you, ma'am. Bobby, ma'am, that was really very comprehensive. And I think you've covered all the points, right from pre-op, intra and post-op, which is a very important thing, and which we always tell everybody to follow, because most of the people think that when we talk about OT, it is only about air pressure and what is happening within the OR. But there are a lot of, as you rightly said, a lot of things which go from starting from the pre-op period and extending beyond throughout the post-op period, right from wound care and patient education, dressing of wound, aseptic handling of wound at home. And that, I think, has been covered extensively. Thank you so much. That was really very nice. And ma'am, there are a few questions which have come up on the chat box. I'll read it out. I think one or two. One, basically, they've asked, can we use brush to clean nails? So I have answered that we can use. Usually it's done at the beginning of the day using a disposable nail. Should be dedicated for every person. The other thing is, how can we do root cause analysis for surgical site infections? So, ma'am, would you like to take that?
Yeah, root cause analysis. If a patient has developed an infection, you need to definitely, as I said, all the 360-degree you need to be looking into, because today we have talked about beyond the incision. So we have covered the OT, the CSSD. So definitely in the CSSD, whether on that day, whether the patient, which load was used for the, which pack was used, it was in which load, whether whether the chemical indicators, the biological indicators were used appropriately, and whether the sterilization was done properly, whether the temperature hold, whether appropriate temperature, appropriate pressure, everything will be documented in the CSSD register. This has to be checked. And then in the OT, in the schedule, in that particular OT room, apart from that patient, any other patient got operated on that day, that can be looked into, and whether anybody else also developed SSI, whether it was just one patient, whether it was more patient. And then, as I said, CSSD, then whether it was only a particular set which was used, whether on that load many other patients also developed infection, how was the cleaning done? And between the surgeries, cleaning is very important. Many a times doctors are in a hurry to finish their surgeries and go back to their OPDs. So they push the patient themselves. They will run and get the patient themselves without waiting for the staff to get the OT clean. That is one of the major concern which the OT nurse will raise, or the OT manager. Ma'am, they don't give us time. They just push in the patient, the next patient. No. The nurse in charge there has to be very, very firm. Whatever time, 15 to 20 minutes taken for cleaning is very much required, for maintain the sterility of OT. So whether it was cleaned in between, thorough cleaning was done, whether any other surveillance methods were used, the reports have to be looked into, and then who did the surgery, who assisted in the surgery, and then you have to come back to the ward, how the patient was taken care of, and all those things, how the wound care was done. So all these things, and then patient went home. At home, whether the patient followed hygiene, whether the dressing was dirty. Questions can be asked about the self-care and hygiene aspect, how they were looking into. So many aspects of this has to be, and whether the patient was provided a surgical antibiotic prophylaxis. So these documentation also have to be checked. So you have to look into a lot of these aspects to do a root cause analysis of a surgical site infection. And whether the patient was diabetic means whether the patient's blood glucose was kept under control pre and post operatively, whether the patient had any other comorbidities, all these things have to be looked into.
Yeah, so basically it's like a 360 degrees investigatory process when you talk about an RCA for surgical site infections. A lot of things really need to be taken into account, and therefore, as ma'am had rightly put it, divide your RCA questions into pre, intra, and post, and then look at all the components of it. Then you'll be able to really make a very organized way of looking at what has gone wrong or which are the gaps. Ma'am, the other question is OT fumigation recommended?
No, as per the latest guidelines, OT fumigation is not recommended. That will damage the equipments also in the OT. A thorough cleaning with an appropriate disinfectant would do. Thorough deep cleaning.
Deep cleaning, that's right.
Yes.
Yes, ma'am.
Some of the hospitals which I visit, they are doing even liver transplant, and they are doing only a thorough deep cleaning.
That's right, ma'am. Actually,
some of the doctors are very adamant that at least fogging to be done. Some of the old time doctors want fumigation. So it's all about evidence-based guidelines. So if the staff are able to show the evidence-based latest guidelines to the doctors and convince them, do a study that this is the latest evidence-based. If you have 2 OT, 1 OT, let us follow this one OT, let us need not do this thing, and then you come out with a result at the end. If it doesn't make any difference, then why fumigate? You need to talk to the doctors with rationale, and you can definitely convince them.
That's true. I really agree with ma'am. I mean, getting science and data when you talk to somebody really makes a big difference. And another thing is what ma'am said is doing a pilot study. Whenever you talk about changing a particular practice or a protocol, which people have been following for a number of years, it's not easy to say that, okay, boss, let's do something different the next day. You really need to do some sort of a pilot. So that's a very good idea, ma'am. The other thing is one person has asked, ma'am, scrub nurse movement register is required as per NABH? No. Okay. And
you need to maintain the details of who was the scrub nurse and who was the circulatory nurse and who was the surgeon and who were assisting it. These documentation has to be done, but scrub nurse movement register like that, it is not required.
Okay, ma'am. And infection control in emergency theaters versus infection control in elective theaters. Is there any difference?
All theaters have to be treated alike.
Yeah.
Nothing called emergency theater you can have because it's an emergency. You can follow less of protocols. All the OT, if it is a sterile zone, the entire protocols have to be followed in the OT, whether it is emergency OT, whether it is in the elective surgery OT.
Right, ma'am. And
if you don't.
I didn't understand. There is no shaving is recommended for 7 days, then there will be chance of infection with hair growth. I really didn't understand this question. I'll not really put this up. Is chemical sterilization recommended for surgical instruments?
No, somebody has mentioned that if shaving is not done with the hair growth, then patient will know. Nothing like that. Shaving leads to micro cuts, and that
I didn't understand the question actually.
So shaving is not recommended at all.
At all.
It is recommended. Yeah.
Yes, ma'am. And is chemical sterilization recommended for surgical instruments cleaning, followed by pre-cleaning with enzymatic solution or not? So chemical sterilization, Mani, I think are they mentioning high-level disinfectant?
I do not know. First, you have to wash and clean with the enzymatic solution.
That's right, ma'am.
Initially with the enzymatic solution, and then only it goes for sterilization.
Sterilization. So none of these surgical sets instruments should be HLD because they're all critical items.
Yes,
So
yes.
absolutely no question on using any sort of chemical sterilant for surgical sets.
Right.
Am I
Yes.
right, ma'am? Yeah.
Correct.
Yeah, and I think there is some confusion about using the nail brush. I think I don't know, because some people say you should not use the nail brush. CDC guidelines says not to use nail brush. It can damage the nail bed, increase shedding.
If the latest guidelines, if they have any latest guidelines, then they should be able to show the guidelines. If it is mentioned, then they need not.
Right, ma'am. Hair removal before surgery is a question mark by Sean. I mean, I think ma'am has already covered that. And I think many times...
with the trimmer, when we remove, it is at the skin level only, it is
skin
removed.
level.
Not
Yeah,
length.
and it is only at the surgical site. We don't go to the older practices of shaving the whole patient. So those things have definitely come down. Only the surgical site preparation is basically clipped and not shaved. So any criteria to check efficacy of ultrasonics or the enzymatic cleaning agents? Yeah, so there is one soil test which we do for ultrasonic cleaner washer disinfector, which comes with the machine if it's an automated cleaning. That's what we do. Enzymatic cleaning, I think, ma'am, as you would agree, the major thing to look for as a quality assurance is to check the dilution of the enzymatic solution used. When you're dipping the thing, and whether you're pairing the correct dilution of the enzymatic solution, and whether you are keeping it for the right amount or soaking the instruments for a correct amount of time. I think that's the main QA which normally should be followed. For ultrasonics, yes, washer disinfector, there is a test called the soil test, which can be used as a QA. Ma'am, one thing is, ma'am, obesity is a concern for SSI.
Obesity, if you cannot say, until unless the patient is having other comorbidities and diabetic and the site of surgery. Otherwise, I don't think so. Just obesity, will lead to SSI.
Again, ma'am, I think obesity we need to define as per the BMI. So obviously, you have obesity. Anything above 35 is called as obese. So you have mild, moderate, and morbidly obese. And of course, obesity, morbidly obese patients. Definitely is the greatest, is one of the potential.
For gaping of wound also, morbidly obese.
Visceral fat also, ma'am. Many cases we have seen. Not only is the BMI, many people may be within the BMI, but they may have a lot of visceral fat, like a pendulous abdomen, lot of fat distribution in the umbilical and lower abdominal.
Mostly, if you see this morbidly obese, people will have other comorbidities.
Exactly. So they will definitely have metabolic syndromes, wherein they will have diabetes type 2 and other issues. So it all comes as a package. So you have to definitely take into account obesity and, of course, other comorbidities which come. Somebody has asked, cleaning with glutaldehyde solution. I think we've already answered this question. Surgical instruments are critical instruments. They should be sterilized. Pressure gauge mandatory in the OT.
Yes.
Yes,
pressure
definitely.
Gauge is mandate in the OT.
Yes. And somebody had asked, how do you measure the pressure gauge? So we do have pressure. So we do have pressure monitors or gauges outside. Uncontrolled sugars can be taken as a concern for SSI. Yes, ma'am has already covered that point. Definitely. Are they mandatory protocols as per guidelines that soil test is necessary in washer disinfectants? Yeah, there are. It comes as a part of the washer disinfector manual, and the protocol is there for doing a soil test. It's one of the mandatory requirements. Okay, maybe. Okay, I'll just check the chat. So when patient goes home after discharge and comes back with SSI, what are the causes? I think that's what they've tried to ask, though it's a very half question which has been typed. I think that's what probably they've tried to ask. Patient goes home after discharge and comes back with SSI. So whoever has asked this question, could you please type the remaining of the question, because we didn't understand whether you're asking that is it possible or is it due to what reason? Yeah, I think we are done.
Yeah,
Most of
the present guidelines and the studies have not showed any significant result by using nail brush, whether it decreases bacteria or not. So it may not be recommended.
Yeah.
In olden days, they used to be using nail brush.
Yes. Yeah. Can we consider emergency surgery SSI in calculation of SSI compliance rate?
All surgery
ma'am-
has to be included in the
Yes.
SSI rate.
Yeah. Many questions in the chat. I'm not seeing anything in the chat.
Yes, ma'am. We are having questions in the chat session.
Manisha, where is? I'm not seeing anything. Oh, this chat.
Click
Okay.
in the all option. You can see the questions. You must be seeing in the organizer. You can click on the all, madam.
Beside organizers, there is all.
Okay, I understood. Yeah, good.
Madam, there is one more question on fumigation. Madam,
Yes.
what if we have more than 200 cases in less square feet of OT as per the demand? Then also, is it not required fumigation?
I didn't hear.
Shall I answer that question, ma'am?
Yes, please.
Yeah, so basically, see, fumigation and fogging, we now call it as fogging, is basically recommended only in specific conditions, as ma'am has already told. That is, there are 3-4 conditions. One is if you're commissioning a new OT, or if there is any construction or renovation activity. The third is if you have an increased number of infections and you have actually identified environmental culture, surveillance cultures to be positive with fungal spores, etc. Then yes, definitely we need to look at first before fogging. That's only the end of many of the things which we need to do. The first thing is, as ma'am said, is a proper thorough cleaning, looking at your AHUs, air handling units, looking at your engineering controls, looking at your HEPA filters, your pre-filters, cleaning and maintenance of these filters, cleaning and maintenance of the air conditioning unit, right? And then looking at all other sources of which could contribute to your infections in the OT, right? So this is something which we normally do. Before we finally, at the end of doing all this cleaning, maintenance, and rectification of these issues, then only we finally do what is called as fogging. So definitely, if you are 100%, confident of your engineering controls, and if you have a modular OT and a good air handling unit, I'm not talking about window ACs or split ACs. If you have a good centralized air handling unit, which itself contains an air conditioner and your HEPAs and your pre-filters, then definitely there is no need for you to be scared. You can definitely do away with fogging, even if you're doing 100 cases or 200 cases. That is not the point. The point here, as ma'am said rightly, is what is the time you're giving for cleaning and disinfection of cases? As ma'am rightly said, most of the times, my OT nurses will say, ma'am, they don't even give us 10 minutes to clean. Then how can you say that, do fogging? Fogging is not a solution, is not the end answer for all non-compliances. Like how we use antibiotics, okay, as an end answer to treat all activities, all infections, whether a patient has fever, give antibiotics. It is not like that. Similarly, if the theater has got an issue, it cannot be rectified just by fogging. So you have to look, even if you have a particular square feet area of the OT, is your engineering control working fine? And that is the reason, as ma'am said, we need to measure the temperature, the humidity, the pressure on a regular basis and see if there are any outliers which you can identify in a day. If there are persistent outliers in a day, you know that your engineering controls are not up to the mark. Okay, they're non-compliant. So get that rectified rather than resorting to fogging, right? So we do not, as ma'am rightly said, there are a lot of old clinicians, surgeons, it's very difficult to work with them. They say that, okay, I have cases. You don't fog anything, you don't do anything. Okay, that's one question. The second is, ma'am, we also have auditors, from NABH coming and asking, where are your surveillance cultures? Where are your fogging reports? What is this? So the thing is, as ma'am said, science and data and evidence only speak. There are many times wherein we ourselves have shown the latest recommendations to the auditors and said that, ma'am, we are following this. We are sure of our engineering controls. We are sure our HEPA filters are validated and calibrated. They have passed all through all the tests. We are sure our cleaning is happening. We have a cleaning efficacy monitoring test, like either a ATP luminometer or a surveillance culture, which is proving that every time your cultures are negative, your OTs are free of microbes. And that is the reason we are not fogging. Then nobody will tell anything. Right?
Yeah, we need to have the latest guidelines, and if assessors cannot demand it has to be like this, because every assessor come from different hospitals with different practice. They cannot demand the practices in their hospitals, or it has to be like that. They cannot be telling your hospital, your protocols based on the latest guidelines. Have your guidelines ready. Many a times, even when I used to be going as an assessor initially in high-tech OTs and things, I have learned a lot from them, because they have all the latest this thing, and then you get to learn also, okay, these guidelines are available. So have your latest evidence-based guidelines with you handy, and then you discuss with the auditors, and they will not be, refusing, or they will not be demanding further.
Right. Yeah, so that's one thing which is really a controversy. So I think that's important. Instrument cleaning method, I think ma'am has already discussed. Hair removal, we have finished. Most common laryngoscope is not high-level disinfected. All laryngoscopes definitely should be high-level, put into HLD before use. So the ma'am, any comments on this?
No, same what you said, doctor.
Yeah.
Some of the hospitals post-COVID, I see they are using disposable laryngoscopes also. In my previous hospital, the entire ours was a JCA accredited hospital, and every time, every cycle, the surveyors used to come, and they will, write an NC that laryngoscopes are being reused. So then during COVID time, any which way for safety purpose, we were using disposable, and that continued as a practice. For some of the doctors, they were finding it difficult from the routine regular laryngoscopes to the disposable, but now they are using the disposable laryngoscope. And high level, if you are not using disposable, then high level disinfection is recommended.
Definitely recommended. High level disinfection definitely recommended. But again, as ma'am has already spoken, any disinfectant, any sterilization will not function if you have not done cleaning. Removal, pre-cleaning, decontamination, and only then either disinfection or sterilization. This is extremely important. And high level disinfectant, please read the label of what they use, ma'am. Many times people don't read whether it's an immersion time of 20 minutes or 12 minutes or 7 or 10 minutes. So as a standard, everything is not 20 minutes. 20 minutes is only for glutaraldehyde. Please read about instructions for use for any high-level disinfectant which you're using. There are lots of HLDs which are available in the market. Each one has got their own pros and own cons. So read them and please stick to those specific things. Right?
Manufacturer's recommendation has to be looked into, because sometimes when we go to the OT and ask what is the disinfectant you're using for floor cleaning and what is the dilution, they will tell a particular dilution, but then when you check it in the bottle, it is written some other dilution.
Correct.
And then we write it as a NC. So staff need to be educated that each brand will have different dilution. So what is the brand, what is brought in the hospital regularly, and if there is a change in the brand, the staff have to be, especially the housekeeping staff, have to be educated on the same, and nursing staff also have to be told to check who's supervising this cleaning and all. They need to be educated to check on these dilutions. Yeah,
definitely, ma'am. That's a very important point which even I have come across. It is very important to train the staff, not only the housekeeping, even the nursing, when you introduce any new product. And please do not believe the vendor. Always, some of the hospitals said that no, this particular HLD, they said the vendor said that this can be done. No, please go as per instructions for use. Ask them for their scientific data, IFU, ask them for literature and efficacy studies. This is very important. Yes. Okay. Antibiotics generally given 3 to 5 days post-op. Is there any recommendation? No recommendation. The recommendation is, as ma'am said, for 24 hours only, up to 48 hours for cardiac surgeries and for implants or ortho surgeries. But otherwise, generally, it is only for 24 hours, right? And actually, as per international guidelines, it's a single dose, which obviously Indians nationally we don't follow, but at least.
I had a cesarean 24 years back. I was given just one intraoperative dose of antibiotics.
Yes, definitely. It doesn't make. The major thing of antibiotics when we talk about surgical prophylaxis is only to target the skin of the patient. It is nothing to do to treat any infections. If the surgeon feels that there is an infection on opening of the patient, then he has to switch from prophylactic to therapeutic dose or therapeutic antibiotic, not continue the prophylaxis. This difference we need to tell to the clinicians. Okay, so definitely no recommendations to continue beyond 3 to 5 days. Ma'am, what if we have more than 200 that we have finished? How often should air sampling be sent? Again, as ma'am said, I think it's up to each hospital's protocol and OT's protocol. If you're doing a fogging, then obviously after that you can definitely do an air sampling. But an air sampling surveillance cultures are again specific recommendations when you're commissioning a OT, if there's any construction renovation activity happening, when you're looking at the OT environment for the root cause of your infections, then of course air sampling needs to be sent. Otherwise, generally what people do is they do a fogging on a weekly basis or once in 15 days. Post that they send a air sampling. There are no specific recommendations as to the frequency of air sampling. Spurti has asked, ma'am, is settle plate sufficient or OT swab culture is needed? Okay. Surveillance is definitely now we have to move. Please move away from these swabs. Okay, and from these plates, use your air samplers. They are the best way of sampling. See, when you're sampling air, you have to obviously suck in air, right? Otherwise, if you keep plates down on the floor or whatever, you're actually sampling dust, right? So the best way of doing an air surveillance culture is to use an split air sampler. That is the best recommendation. OT swabs are not recommended. Again, don't waste money on these OT swab cultures unless until those three things. Again, those three conditions apply, right? Other than that, no need. Please give me OT checklist for infection control. Okay, maybe we could share if we have it. How frequent OT cultures to be done? We've done, ma'am. Why fogging is not recommended for modular OTs? I think I've answered that, ma'am. So engineering controls are very important. Laryngoscope cleaning. How to prevent NTM port site infections following laparoscopic surgery? Follow the proper cleaning, pre-cleaning, cleaning, HLD immersion times, drying of the scopes, storage of scopes, and use. That's all I would like to say. Ma'am, there's one case when patient came in history of pus discharge after surgery and 48 hours culture sent, culture was positive. This is a very vague question. I think, I don't know whether you're talking about a case which had post-discharge came with an SSI. Patient comes with signs and symptoms. So please do refer the NHSN criteria for definition of a surgical site infection. That should answer your question. Yeah, I think that's the end of that, ma'am. I would not like to take more time of yours. Most of the questions are repeated. If any other specific questions are there, then we could. Okay, there's one question on UV sterilization in OTs. Are we following terminal disinfection UV sterilization in OTs? Is there any standard time period to keep the UV light on? Ma'am, do you have any experience in UV sterilization?
UV sterilization. UV sterilization in my previous hospital in Hyderabad, they used to post-COVID, they were using UV sterilization. And it was not mandate to be used, but then the doctor, the infectious disease specialist insisted. So we had purchased a UV sterilization. So UV light exposure per day around 15 to 30 minutes, they used to keep in a respective, whether it is a patient room, whether it is in the OT, that used to be used. But I have not read any mandate guidelines for UV sterilization. Yeah.
Right. So during longer surgeries, can we keep soiled instruments with blood in the normal saline or water to prevent drying of blood? Yeah, you could soak them or you could wipe them with a wet gauze, whichever is convenient. The major idea is to prevent drying of blood because then it becomes very difficult to remove it. Could you suggest SSI guidelines, national, international? Please follow the CDC guidelines. There are WHO guidelines. There is IDSA guidelines, SHIA guidelines. All these are guidelines. There are specific guidelines for operating theatre by AORN. Those also can be followed. Ma'am, with what disinfectant ambu bags are disinfected? Ambu bags, you need to just, disinfect it with the 70% alcohol. That will be fine. It's not really a very, see, first of all, when any question comes to us asking about whether this equipment needs to be sterilized or can be intermediately disinfected, should it be subjected to a high level disinfection, the major thing which you need to consider is it a critical item? Is it a semi-critical item? Is it a non-critical item? I think all of you know about Spaulding's classification. Critical items are those which are in direct contact with blood and body fluids, enters into a lumen or organ space. Those needs to be sterilized. There's no question of high-level disinfectant. If you're talking about semi-critical items which just enter the mucous membrane, do not really enter into lumens or organ spaces, then those are your scopes and other accessories, which basically what we recommend is a high-level disinfectant. And non-critical items which generally don't come in contact with any blood or body fluids, like your ambu bags, your other equipment which you use, accessory support equipment for patient, obviously you can use an intermediate or a low level disinfectant like 70% alcohol. We don't have HEPA filters in ICUs. We keep all post-op cases, then most of them are infected. Is this the cause of SSI? To how extent as few are getting discharged without infection? Okay, so basically the question is that, ma'am, a person is asking whether, if they are keeping in they are basically discharging their post-op, housing their post-op cases in a particular ward which doesn't have HEPA filters, not required to have HEPA filters in post-op recovery wards or bays. Yeah, it's not recommended, and there's no need to really look at it. That is definitely not the cause of SSIs. SSIs is a multifactorial thing, so please group your RCAs, as ma'am said, as pre, intra, and post, and look at those points. You would definitely get more amount of information on those non-compliances. How often should biological indicator use for ETO and plasma sterilization? So I think for BI for plasma is weekly once is what I know. For ETO also, it depends upon the ETO machine and the thing. Generally, it is weekly once. That's all. Okay, which we
every
do.
load.
Every load is what ma'am is saying, right? Yeah. Okay, so every load, that is your chemical indicator, no ma'am, or your biological indicator too?
Biological indicator also for all the implant cases you need
implants,
to use.
yes. So basically all implants, you have to have a BI within every implant set. That is important. But for other non-implant, it is usually weekly ones. How can we do
minimum weekly ones?
Weekly ones, minimum weekly ones. How to do a split air culture? So you have split air sampler machines, which can actually suck in air, and you can put a plate within it, and you can actually suck in air and examine that volume of air. You can culture that particular volume of air within the OT. There is a specific instructions there are for use when you talk about the split air sampler. Yes, so please do refer to that. What ICN or ICU needs to check from engineering control perspectives? They are not trained on validation tests for HEPA or ACH. How to check?
So NABH has given guidelines for OT. If you Google search, you'll get the OT engineering control guidelines. And this, they have to ensure the maintenance team in the hospital will be in charge, but at least the values are written. You can check the document for the values. And temperature, humidity, daily you can check that. And air velocity and other things. Some of the hospitals have their own instrument called the anemometer.
Anemometer.
For checking the air velocity.
Okay, I hope that is clear. The HEPA ACH. Ma'am is, I think her network is gone. Can we use air curtain at the entrance of OT? You can use. It's an additional thing, but it's not a mandate. Air curtains are a no to all places. Yeah, I mean, so basically air curtains have a specific role, especially when you're talking about transplant wards, post-op chemo, neutropenic patients, especially it is, and when you're talking about your pass boxes in CSSD, when you're dispatching sterile items, Okay, in those specific conditions, we definitely like to have air curtains. Post-op normothermia, so important in preventing SSI? Definitely yes. There are several studies which have been proven and which are there in literature, which talks about the importance of normothermia in the intra and the post-op period. So you could definitely refer to those. I think that's it. There are any more questions? I think we'll take it later. Yeah. I think ma'am signal is gone. Could you just ring her up, Manisha, if possible?
Yes, ma'am. Yes, I'm doing.
Madam, we have also conducted a poll during the session, and you can see the poll results and publish them, madam.
Okay. Okay. So in your experience, the first answer in the poll is, in your experience, what do you believe are the primary reasons for prevalence of surgical site infections? Let's see the result. Poor aseptic techniques, 39%. Inadequate patient preparation, 50%. Yes. Okay. Improper sterilization of surgical instruments, 25%. Inadequate post-op care, 41%. And contaminated surgical environment, 29%. Yes. Yeah. So this is fine. Definitely, inadequate patient preparation methods are extremely important. One of the major leading causes of SSIs, and that is why we normally talk about using a pre-op chlorhexidine body wash, a medicated body wash before the patient comes in. Okay, preparing the using of clippers instead of shaving for removal of hair. These are some very basic things which play a major role in prevention of SSIs. Which surgical hand scrub do you prefer to use most often? Wonderful. It's good. Chlorhexidine gluconate, alcoholic chlorhexidine gluconate. So chlorhexidine gluconate with 70% alcohol is the recommended and preferred method of using for a surgical hand scrub. There are surgeons who prefer to use betadine. Povidone iodine can be used, but it should be an alcoholic preparation. If you have an alcoholic preparation of iodine, it is also equally good. The only disadvantage of using iodine over CHG is that iodine takes a lot of time to dry. Okay, so you need to wait. But otherwise, definitely both are recommended. The current recommendation is chlorhexidine with 70% alcohol. The others, if some surgeons are allergic to CHGs, there are a few, then they can definitely use iodine, but not aqueous iodine. It should be alcoholic iodine. Ma'am, sorry, your network was bad. You got stuck.
I thought you were not to be seen, so I thought your network was gone, but I hear you telling my network, then I left and I got connected.
Yes, ma'am, we're just going through the poll questions, so I thought I'll just do that. So we had a poll of 5 questions. I think you can also see it, ma'am. Are you able to see it?
Where it is? Where I should check that?
In polls.
Polls.
Just go to...
Polls. 1 second. Polls, okay. Yeah. I saw the polls.
So we finished the first 2 questions.
Okay.
The third one is, how often should the entire OT be thoroughly cleaned? You go to the results.
Mm-hmm.
It's good. So people have paid attention and have really understood the importance of cleaning and disinfection of the OT. Yes, 77% have voted that definitely daily, on a daily basis, it should be done. And of course, in between patients, at the end of the day and at the beginning of the day. Yes. Which zone in an OT is considered the aseptic zone?
Zone
3. Very good.
Mm.
Then, which environmental factor is most important in preventing airborne SSIs?
Okay.
Definitely.
Ventilation with HEPA filters, yeah.
Yes, it is. But as ma'am said, I'm more worried about the number of staff in the OT many times. Yeah. So thank you all. I think that's about the poll. And ma'am, really thank you for a wonderful session. Very nice interactive session. We had a lot of good questions and a good interaction from your side. Thank you once again from SANMED for your valuable time and your experience, and for enriching this session. Thank you so much.
Thank you so much, madam, both of you. You made the session live, and most of them have got the whole context what both of you wanted to share. The questions were quite apt and the poll went on well. As expected, they were able to get the information what you have shared for the last 1 hour with them. Thank you so much from SANMED. All of us, thank you so much and continue to see you and meet you again. Thank you so much, madam. Thank you all for attending. We'll catch up in the next Tuesday. Thank you, madam.
Thank you, Dr. Sukanya. It was nice interacting with you virtually. Sometime we'll meet in person as well.
Definitely, ma'am. Hoping to see you. Thank you so much. Pleasure is mine.
And thank you, audience,
Thank
for your participation. Yeah. Bye.
Thank you,
Thank
madam.
you all.
Thank you so much
Thank
for
you.
your time.
Thank you, sir.
Thank you all. Thank you, ma'am.